The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hello, everyone. Welcome to your internal medicine module of your top-notch medical board preparation for the physician licensure exam. So before I formally begin my lecture, let me just give you an overview. Your IM module will be taught by several faculty members of top-notch medical board prep. Each of us is specialized in specific disciplines of internal medicine, so we can discuss it in more detail. We can highlight the important topics that's very important that you need for you to remember in actually tackling the boards. We have listened to the feedback of the previous batches, and of course we have improved and updated our lectures and handouts in order to adapt to the changing trends of the physician licensure exams. Again, I'm Dr. Mark Denver A. Tiongson. I'm an internist, a cardiologist, and an interventional cardiologist. And the first module assigned to me is, of course, cardiology. So anything that pertains to the heart. So the outline of our session right now is about these illnesses, your ischemic heart diseases, your valvular heart disease, which will focus on mitral stenosis and aortic regurgitation, of course, heart failure, Brugada syndrome, and your cardiac tamponade. With these lectures in internal medicine, I hope that you also learn from all these diseases that we have nitpicked. Due to the limited time we have to select these specific topics which we think are very high yield in answering the boards, but we encourage you to read the entire handout from page 1 to the last page. On top of this, we also hope that you also study the materials very hard in order for you, for your maturity as a physician, magamit yung mga knowledge na to para makapaggamot ng pasyente, hindi lang para makapasa sa board. So, two things, maaral ninyo para makapasa sa boards, and of course, para maging magaling kayong doctor sa future. Again, these are the topics, and of course, let me begin with ischemic heart disease. So, what is ischemic heart disease? This is a condition or a constellation of symptoms that where patients experience anginal chest pain, that may either be an acute coronary syndrome or your chronic coronary syndrome. So these are the two spectrum of your ischemic heart disease. So pwedeng acute, pwedeng chronic. All right. Some students ask, Doc, why is it called chronic na agad, when the patient did not suffer an acute coronary syndrome? Okay, in terms of nomenclature, mga kapatid, future colleagues, yung acute coronary syndrome, hindi nagbago yung terminology dyan over the years. It is still the heart attack. And it is classified as non-ST elevation acute coronary syndrome, which is previously known as either your NSTEMI or your unstable angina, and of course, your ST elevation myocardial infarction, which we are going to discuss in detail a little later. Now, maraming nalilito dito, chronic coronary syndrome, In the recent years, particularly the Europeans, they have actually evolved in coining the different terms already for your stable angina pectoris. Before, the old nomenclature was the chronic stable angina pectoris, and then we named it as your stable ischemic heart disease. In the 2018 guidelines, they are now labeling it or calling it as chronic coronary syndrome. Kailangan ba magkaroon ng heart attack bago maging chronic coronary syndrome? The answer is no. Again, this is the new term for the stable ischemic heart disease, or the oldest term na chronic stable angina pectoris. All right. So for patients with ischemic heart disease, the most common symptom, when we say kasi anginal chest pain, this is a chest pain that is secondary to cardiac in origin. It can be described as your squeezing, in character, or pwedeng heaviness, no? Or sometimes there's this diffuse discomfort, no, that traverses or parang radiates from the mandible down to your umbilicus, no? So these are the levels wherein um, the chest discomfort or pain can be experienced by your patients below the mandible, above the umbilicus. Below sa panga or batok, no, tataas ng inyong mga puso. So, when your patient comes to the ER or clinic, no, and complaining of chest pain, how do we approach these kinds of patients? Of course, we always go clinical, no? So, how do we approach the chest pain? Epidemiology-wise, no, they will tell us that the most common of acute chest discomfort at 8% shy, no, which is 40% of the time, it is due to gastrointestinal symptoms. The great mimicker of anginal chest pain is actually your gastrointestinal symptoms. Pwedeng GERD, pwedeng acid peptic disease, no? Pwedeng ulcer, pwedeng gallstone. So these are the more common causes of your acute chest discomfort. And second to it, and the more serious one is, of course, your ischemic heart diseases, which can be subdivided into your acute coronary syndrome and your chronic coronary syndrome. And it's followed by your chest wall syndrome, your common costochondritis, pericarditis, pleuritis, and so on and so forth. No? So, given this variety of differential diagnosis, paano ba natin siya dapat ina-approach? Kung yung pasyente pumunta sa ER, paano ba natin siya dapat tignan, no? Are we going to look at the more benign conditions first, or are we going to look at the more serious complications first? So, the first important question that we have to answer is that, is the chest pain could be potentially due to a life-threatening condition that warrants urgent evaluation and management. And what are these chest pain etiologies? This is, of course, your acute coronary syndrome, aortic dissection. Again, aortic dissection, the aorta napunit, no, because of atherosclerosis. And if it actually the tear travels up to the aortic root, no, kung saan nakakonect sa puso, this is very dangerous because it can cause your acute regurgitation, no, acute aortic regurgitation, which I'll discuss more in detail, and it's very fatal. Pneumothorax, of course, as you may have known in your surgery lecture, tension pneumothorax can cause severe hypotension because it impedes, no, the systemic venous return, and of course it will cause your lung collapse, causing respiratory distress, and of course it can also cause death if not treated emergently. And lastly, the pulmonary embolism. Kung merong brain attack, which is your stroke, kung merong heart attack, which is a blood clot, no, that's obstructing the coronary arteries, the brain attack or stroke, which is obstructing your cerebral arteries, and we have the pulmonary embolism, which are blood clots obstructing the pulmonary blood flow. Of course, if the blood clots are lodged into the main pulmonary trunk, no, main pulmonary arteries, there will be impediment of blood flow. Magkaroon tayo ng lung infarct, causing mismatch in oxygen, no, will cause respiratory distress, and of course can also cause demise. So these are the important considerations. So how will you distinguish one from the other? ACS, of course, you have your traditional risk factors, patients more than 50 to 60 years old, patients with diabetes, hypertension, hypercholesterolemia, aortic dissection, should have the constellation of your smoking, cholesterol intake, no? For patients with pneumothorax, particularly, they could be young or old, no? With history of TB na nag-rupture yung bleb, or there's a chest trauma. Pulmonary embolism, usually it has an underlying cause. Yung blood clot that lodges to the main pulmonary artery usually comes from your deep veins, no? So these are patients who are prolonged immobilization, those who are having a long haul flight, no, 16 hours, hindi naglalakad, nagdi-DVT, tapos biglang nahiningal, pumupunta sa lungs, no, pwede mag-cause ng pulmonary embolism. Or patients who have cancer undergoing treatment. So these are the patients who are high risk for venous thromboembolism. All right. Now, if we have ruled out all these four parameters, no, the next question is, can the chest pain be secondary to chronic condition leading to a serious complication? Examples of these include your chronic coronary syndrome, or previously known as your stable ischemic heart disease, or your chronic stable angina pectoris, or your aortic stenosis, and of course, your pulmonary hypertension. So, patients with CCS, alam na nila yan dahil madalas nila na-experience, no? The usual typical presentation is kapag there's an exertion, nakakaramdam ng pagbigat ng dibdib, nawawala pag pinahinga. Patients with aortic stenosis leading to chest pain are those patients who have very, very severe aortic stenosis. And of course, on your PE, you might hear systolic crescendo, decrescendo murmur, which is actually located at the second ICS right parasternal border. For patients with pulmonary hypertension, of course, the WHO classification, the most common cause of pulmonary hypertension in the local setting could be your COPD, your mitral stenosis, and of course, the idiopathic ones, your CTEPH, So things like that, there are certain conditions that might cause pulmonary hypertension, and for sure congenital heart diseases. So if you're able to rule out these three, the next question is there an acute condition that warrants specific treatment, such as your pericarditis, pneumonia, pleuritis, or herpes zoster, This pericarditis can be diagnosed. Usually, may certain characteristic yung patient, Kailangan pag titingnan yung mga patients sa may pericarditis, usually, hindi sila comfortable na nakahiga. They usually assume a tripod position, leaning forward, That is the most comfortable position for them. For patients with pneumonia and pleuritis, usually they present with chronic cough, sputum production, and of course, for herpes zoster, you'll see characteristic lesion that is dermatomal in nature, So, in addition na lang sa pericarditis, kapag nag-auscultate kayo doon sa heart, you might hear friction rub. But again, the absence of friction rub does not rule out the presence of pericarditis. So, you might want to request an ECG, wherein pericarditis might present with diffuse ST segment elevation, except for lead V1 and of course your AVR. Alright, again, pericarditis, diffuse ST segment elevation, except for leads V1 and your AVR. Now, if we're able to rule out the following, ito yung mga usually more benign conditions, Again, the dictum is you to rule out the more serious before you consider the more benign conditions. So this includes your esophageal reflux, spasm, ulcers, your gallbladder disease, cervical disc disease, your rheumatologic conditions, costochondritis, and of course, anxiety. Anxiety is usually common among young female patients, who are undergoing severe stress. But again, I'm not limiting it to women. I have seen patients who are male in their 30s or 40s also has complaining of anxiety disorders. I was able to send the patient for stress test, 2D echo. Minsan nga, mayroon pang umaabot sa angiogram, Pero yun na nga, walang nakikita. And true enough, they're very anxious, and probably the ones that they need are, of course, mental health issues, and they might require psychiatric psych consult. All right. So these are the summary, of how you can determine or differentiate your ischemic from your non-ischemic chest pain. Again, I want you to focus on the ischemic. This is usually sudden in onset. There's an increasing intensity provoked by an activity, This may respond to sublingual nitrates, of course, for the chronic coronary syndrome. But for ACS, acute coronary syndrome, may not respond to your NTG. Usually, they're described as sharp, squeezing into character, heaviness. Sometimes may radiate to the dorsum of your arms, to the jaw, and there's usually diffuse and lasting more than 30 minutes. Usually for chronic coronary syndrome, it's less than 10 minutes. All right. Now let's discuss the two spectrums of your ischemic chest pain. First, the chronic coronary syndrome. So again, chronic coronary syndrome is the modern new term for what we usually known as the chronic stable angina pectoris, and of course, your stable ischemic heart disease. Let me start with you by discussing or presenting a case. A 53-year-old male, hypertensive, presenting with heavy substernal chest pain lasting for 5 minutes, relieved by rest. So important, the reason why I bold this significant words in the case is that I want you to when you're reading a case, for example, sa board exam, gusto ko pag tumitingin kayo na natitrigger na yung mind nyo, yung memory nyo, ano yung kailangan matandaan ninyo. Same holds true when you're doing an history or physical examination. Ano yung dapat tumatatak sa utak ninyo kapag nagtatanong kayo sa patient or kapag ina-analyze yung case ng patient. So, 53, again, may risk factor ka na for ischemic heart disease. Hypertensive is again risk factor. Your description of substernal chest pain, no? During exertion, that's very important, no? That's very specific. Exertional chest pain lasting less than 10 minutes. So in this case, 5 minutes, relieved by rest. This highly points to a chronic coronary syndrome. So what's most likely diagnosis? It's CSAP or your chronic coronary syndrome. What's the underlying pathophysiologic mechanism? There's an imbalance between the oxygen supply ratio, no? Supply and demand ratio. And usually this is brought by the coronary atherosclerosis, epicardial coronary artery narrowing. So what's the first initial approach? Again, history and PE, just like any diseases. And the best initial diagnostic test is ECG because you want to rule out an ACS. And the next step is perform a stress test. And the first line of treatment to reduce angina is, of course, your beta blocker or your calcium channel blocker. Why? Beta blockers or your non-dihydropyridine calcium channel blockers can, of course, decrease the workload of the heart. Going to your cardiac physiology, remember that oxygenation of the heart happens during, I hope you are able to answer that in your memory, no? During diastole. And remember, if there is an increase in heart rate, no, there is your decrease in your diastolic filling time. Kaya magkakaroon ng chest pain. So when you initiate beta blocker treatment, you reduce the workload of the heart, you prolong the diastolic filling time, and you therefore increase the oxygenation of the heart. All right. So chronic coronary syndrome, again, is previously called of your CSAP, your stable ischemic heart disease. It results from the imbalance of your myocardial oxygen requirements and supply. There are several types. We have the demand angina, wherein there's an increased myocardial oxygen requirements, no, in the presence of a constant and usually restricted O2 supply. Classic example, narrowing of the epicardial coronary arteries, hindi makapag-flow yung dugo dahil may pagsisikip. Para sa highway, rush hour, may ginagawang kalsada, hindi makapass through yung mga sasakyan, causing traffic. Ganun yung nangyayari sa demand angina. Parang imagine a rush hour na may ginagawa sa kalsada, causing traffic. Now, angina caused by transiently decreased oxygen supply. This is your Prince metal variant because of vasospasm of your coronary arteries. And the treatment of choice for this is, of course, your dihydropyridine calcium channel blockers or your nitrates. But we usually prefer your dihydropyridine calcium channel blockers because more often than not, patients develop tolerance for patients with spastic coronary arteries. Again, they present with chest heaviness, no? Described as squeezing, substernal, the Levine sign, radiates to the shoulder or both arms. It's a decrescendo pattern. Typically lasts 2 to 5 minutes and relieve within 1 to 5 minutes of slowing down or resting or taking sublingual nitrates. Again, it's triggered by exertion or extreme emotion. These are anginal equivalents. No? Not all of the time, patients might present with a typical angina. We have what we call the atypical symptoms. And these are more common among elderly, no? Mga 60s and above, women, and of course, those diabetic patients. They might present with dyspnea, fatigue, faintness, near syncope, nausea, vomiting, no? And in some instances, remember that exertional dyspnea, even in the absence of chest heaviness, can be an indicator of coronary artery disease, no? And postprandial angina, if this is present, then the patient has very severe coronary artery disease, no? Because pag kumain lang, ano ba nangyayari? Pag kumain tayo, there's an increased blood flow sa ating intestines, no? Because we want to absorb the nutrients and the proteins, sugars, etc., no? That is being digested in our intestines and the gut. So if there's an increased blood flow in the intestines, aagawan niya yung blood flow sa puso. Of course, there's a supply issue because of the severe tightening of your coronary arteries, nagkakaroon ng postprandial angina. Again, this is a marker of severe CAD. Now, we can classify the severity based on the CCS or your Canadian Cardiovascular Society classification, no? Yung CCS1 kaya makapag ano pa, yun, more than ordinary physical activity, no? Yung 2, slight limitation, no? Examples is walking or climbing stairs rapidly. And 3, konting lakad lang, wala pa. From kama, punta sa pinto, no? Sumasakit na yung dibdib. Yung 4, even at rest, no? Walang ginagawa, nagkakaroon siya ng chest pain. Of course, the more the severe the CCS, it's usually associated, no, with the severity of your coronary artery disease. So what are the diagnostics that we want to see? We use an ECG, no, to check if there are ECG changes such as your ST segment depression, T-wave inversion, Q waves, no, for silent MIs. Chest X-ray if there's cardiac enlargement or congestive changes. CBC kasi nga baka may anemia, no, we want to see if to improve if there's a presence of anemia. FBS, lipid profile, and creatinine. Of course, these are other risk factors that we want to control because elevated sugars and cholesterol can, of course, aggravate your atherosclerosis. Urinalysis is also to look at if there's a kidney injury. Again, if you have CKD already, it causes accelerated atherosclerosis. Echocardiogram, the purpose is number 1, to see if there are wall motion abnormalities suggestive of a coronary artery disease, to check the valvular function, and of course to check the ejection fraction. Ambulatory ECG monitoring can be done, just 24-hour ECG, no? The problem with an resting ECG, it's just check the spot. The 24-hour ECG monitoring, syempre, di ba, pag yung patient's nag-chest pain at the time of the day, having an ECG monitor 24 hours can document, no, the changes in ECG for that time na nagkaroon sila ng chest pain. Stress test, of course, the definitive. It will tell us the functional capacity at high exercise levels or low exercise levels. Meron bang ECG changes? Meron bang ischemic symptoms? Coronary calcium score can look at, it's a CT scan, no, which can look at the calcification of the coronary arteries. And lastly, of course, the invasive procedure, your coronary angiogram. So these are some physiologic tests. Now, again, in the evaluation of ischemic heart disease, meron tayong tinatawag na anatomic and physiologic. This physiologic test tells us if there is really an imbalance in the oxygen demand and supply. And these are the different sensitivities of this test. The stress ECG, wherein mag-jogging lang yung patient habang minakabit ng ECG. Titingnan, kailangan maka-target ng 85% ng maximum heart rate. So how do you compute for the maximum heart rate? It is 220 minus the present age, no? That's the maximum heart rate. And that ideal target is it's 85% of your maximal heart rate. Again, to compute for the maximal heart rate is 220 minus age. For example, hypothetically, I'm not saying that my age is 40 years old or 30 years old, 220, say I'm 40. For illustration purposes, 220 minus 40 is 180. So that is my maximum heart rate. And I need to achieve a heart rate of 85% of 180, which is approximately 150 beats per minute. So the good thing about this is as a cardiologist, I usually prefer stress 2D echo or stress MPI. No? Of course, the cheapest is stress ECG. The most expensive is the myocardial perfusion imaging. What I want about stress echo is that it can see, no, the changes in 2D echo. Ganon din kasi sa echo. Pag resting, pwede maganda yung echo, pero pag ni-stress mo na yung puso, pwede magkaroon ng paghihina ng segments kung saan may bara yung ugat sa puso. So these are really important tests that you can utilize in order to screen your patients, no, for coronary artery disease. So this is an example of a patient undergoing a stress ECG, no. So usually there's a treadmill. We have different protocols, the BRUCE, the modified BRUCE, and the NIH protocol. Stress echo usually takes an echo at baseline and an exercise. So titingnan muna yung heart during rest, tapos patatakbuhin namin sa treadmill. Kung hindi makatakbo, mag-i-inject kami ng dobutamine. Tapos at peak heart rate levels, titingnan namin kung mabilis yung tibok ng puso. Bigla namin siyang ito-2D echo to see if may changes to sa baseline. Now, myocardial perfusion imaging, this is nuclear medicine. So we're going to inject some tracers. We usually use technetium, no? And then of course, we sometimes use your tracers, and of course, we stress the heart, no? Sometimes we use adenosine. We use dobutamine can also be used, So, or then sometimes you can also use thallium as a tracer. So what happens in this is that your heart will be scanned during rest, and of course, will be scanned at stress levels. So if there is a difference, in the uptake, so meaning to say, kung makikita niyo nasa screens niyo, the whiter, the more orange it is, the better the uptake, no? So kapag nagiging purple, nagiging black, ibig sabihin nun may ischemic changes. So it's very difficult, no? This is quite advanced, so this is just an example for you to appreciate. So yung donut, parang hinati natin yung left ventricle into slices, no? Cross-sectionally. And then, of course, there's also longitudinally and then sagittally. So, we want to see the different, ano tawag dito, segments of your myocardium. Another example is your coronary calcium score, no? So notice on the image on the left, yung coronary artery. Kung makikita ninyo, no, kakulay niya yung muscles ng heart. Remember, CT scan uses X-rays, no? High definition X-rays. So so calcium will appear very white. So in the other side, no, the one with the severe one, a calcium score of 1,200, you can notice, no, that there's whitening of the coronary arteries, and having a high coronary artery score, this warrants an invasive invasive test such as your coronary angiogram. This is an example of your coronary angiogram. This is the one that's being cannulated is your right coronary artery, so parang letter C siya. And the one that's being pointed by the arrow is at least the 90 to 95% or the near total occlusion of the proximal segment of your right coronary artery. So how do we manage patients? No, again, we have medications for event prevention. You have your antiplatelets, you have your aspirin, your clopidogrel, your ticagrelor, no? So your PGY12 inhibitors. And then of course your statins. I limited it to atorvastatin and rosuvastatin because your atorvastatin and rosuvastatin, I hope you can read it in your handout, no? The factors on dyslipidemia, that there are two statins which has high intensity doses. That is your atorvastatin, which is dose at 40 to 80. And for rosuvastatin, the dose of is 20 to 40 for high intensity. And of course, you have your ACE and ARBs, no, your enalapril and losartan. Now, we also have drugs for relief of angina. We have your beta blockers, given in your screens or examples of your beta-1 selective. And of course, you have your non-dihydropyridine, your verapamil, diltiazem, your nitrates, your ISDN, ISMN, which are vasodilators, coronary vasodilators. Ivabradine is a newer medication that can slow down heart rate, no, without affecting your blood pressure. It inhibits the sodium fanning channels in the sinoatrial node. Nicorandil is also a second or third line medication to relieve your angina. Your trimetazidine is a medication to prevent beta oxidation in your in the utilization of your fats, no, as the main fuel of the heart. So trimetazidine, you all know, no, going back to your biochem, that the thiolase enzyme is the rate limiting enzyme for beta oxidation. By inhibiting that enzyme, the heart is being pushed to utilize sugar as its main fuel. So remember that you don't need lots of oxygen when you're actually metabolizing sugar. Hence, that's the mechanism on how trimetazidine can improve anginal symptoms. And of course, your ranolazine, which is also is used as an anti-arrhythmic medication. We usually use this for patients with diabetes and angina because ranolazine has A1C lowering effect for such patients. So the goals of CCS management is to reduce angina. And of course, these are your medications, your first and second line. And it is strongly recommended for all of the patients to receive aspirin or clopidogrel if your patient is aspirin intolerant. Statins, irrespective of your LDL cholesterol levels. Beta blockers for post-MI. And of course, ACE or ARB if with hypertension or heart failure. So the question is, when do we send patients to coronary angiogram? Again, these are several factors or parameters. There are 7 instances where you are required to send your patient to coronary angiogram. First, if there's a chest discomfort suggestive of angina pectoris that requires a definitive diagnosis. Second, very important, usually tinatanong to sa board exam, no? Careers that involve the safety of others, pilots, firefighters, or police, no? Who have questionable symptoms. So even if you think that there are other causes, but there is a doubt, no? That this is likely angina, you have to do an angiogram. Pati mga seaman, actually, they are also required to undergo angiogram if there are questionable symptoms. Aortic stenosis or hypertrophic cardiomyopathy in whom chest pain could be due to ischemic heart diseases. For patients undergoing heart surgery, such as your valvular replacement, angiogram is being requested for patients 45 years old for females, and for male, 55 for females, because if there is a note of coronary artery stenosis before a surgery, we want to do the bypass, the coronary artery grafting already, no, kasabay ng pagpapalit ng mga valves. And of course, patients who suffered from PCS or myocardial infarction, and those who tested high risk, no, for non-invasive testing, yung mga sinabi ko, stress test, stress echo, or myocardial perfusion EGG. And for patients in whom coronary spasm or another non-atherosclerotic cause of myocardial ischemia is being considered. All right. So in summary, patients with chronic coronary syndrome has inducible chest pain relieved by rest. Main test is, of course, your ECG or your stress test, stress echo, or your MPI. And to restratify, and of course, you have to give your medications for prevention of cardiovascular events and relief of symptoms. And if there are presence of high-risk features, you send your patient for coronary angiogram. And the definitive management is to do coronary angioplasty or coronary artery bypass grafting. All right. Now, this is the other spectrum of your ischemic heart disease, the ACS or your acute coronary syndrome, or known as your heart attack. At this point, I want you to pause the video, and answer the pretest found in your handout. All right. Okay. Remember your answers for those questions. Check if you got the correct answers as we discussed the acute coronary syndrome topic. Again, if you haven't answered it, you may pause the video, answer the ones in your hand. Okay? All right. If you're done answering, let's resume the discussion. Let's start with a case. A 67-year-old male, hypertensive, diabetic, aspirin, atorvastatin, telmisartan, and metformin was brought to the emergency room from chest heaviness lasting more than 20 minutes. Which of the following will you not consider first? Okay, again, remember, no? Our approach to chest pain, you have to rule out the more life-threatening conditions first. So, in the choices below, the one that is not life-threatening is your aortic stenosis. ACS, chronic coronary syndrome, or aortic dissection are the ones which are more, acute coronary syndrome and aortic dissection are the more life-threatening. Now, between chronic coronary syndrome and aortic stenosis, which is the one that will you not consider first? No, given you're only needed one choice. So ako, if you're going to ask me, I'll choose aortic stenosis. What's the reason for that? Remember, your patient is a 67-year-old male, hypertensive, diabetic. These three conditions alone or risk factors would highly lead you to suspect, no, that this patient is having chronic an atherosclerotic cardiovascular disease, no? And of course, the presentation is chest heaviness lasting more than 20 minutes. So again, the more life-threatening include your ACS and aortic dissection. Between chronic coronary syndrome and AS or your aortic stenosis, I will not consider AS first and would look at chronic coronary syndrome. So for this patient, for this question, I will choose your aortic stenosis. So what is ACS? This is sudden decrease in blood flow. Biglang nawala ng blood supply or biglang kinulang yung blood supply ng epicardial coronary arteries. In contrast to your chronic coronary syndrome, dahang nagbabara yung ugat, no, sa puso ng patient, kaya parang nakaka-adapt sila. While your acute coronary syndrome, sudden na lang nawalan ng blood flow, nabarahan bigla. So, this leads to decrease in oxygen, leading to anaerobic metabolism and lactic acidosis, causing the chest pain, and of course, it will lead to the death of the affected myocardium and decrease in function. Very important to know this very well. If you can memorize this, please do so. No, the different types of MI. Of course, the one that we usually know is your type 1, no, which is your STEMI, the spontaneous myocardial infarction. Type 2 is your myocardial infarction secondary to an ischemic balance, no? So, ano yung mga example ng type 2? Severe anemia, no? Yung hemoglobin from 120 biglang nag-drop to 40. Tapos, meron na rin narrowing ng coronary arteries. That's considered type 2 MI. Type 3 is an MI resulting to death, no, where biomarkers are not available. 4A is related to PCI, MI related to PCI. 4B is MI related to stent thrombosis. So you need an angiogram to diagnose this. And type 5 is, of course, an MI related to your CABG. So what is the pathophysiologic mechanism? Bakit ko pinapakita yung na-pinprick, no, na daliri? Again, contrary to the usual knowledge, no, yung blood vessels, kahit dugo yung dumadaan dun, pwede pa rin masugatan yung ugat, no? So, what happens dun sa ugat or sa sugat natin sa mga kamay? So, or sa anywhere outside the body. So, of course, our body has its mechanism to prevent bleeding. So, pag nasugatan tayo, ang tendency is magdudugo muna, pero hindi naman magdudugo yan forever. Our body will try to stop the bleeding. So, magkakaroon ka ng blood clotting, no? So, ganun din sa puso. So, because of an atherosclerotic plaque, sometimes, no, because of shear stress, nasugatan yung plaque, causing plaque rupture, mag-a-appear si VWF, your Von-Willebrand factor, and this will be recognized by your platelet. Kumbaga, yung VWF, nasugatan, lalabas, hook. Tapos yung mga nagsiswimming na platelet sa dugo, kakapit doon sa VWF. Pagkatapos nun, no, si von Willebrand factor na-activate si platelet magse-secrete yan ng chemicals or enzymes that would attract other platelets to aggregate and causing your blood clot, and also will initiate your coagulation cascade. Kaya yun nagkukos ng blood clot formation. So, the difference between your NSTACS and your STEMI is that your NSTACS has partial occlusion but hemodynamically significant. Your STACS or your STEMI, total occlusion, there is lack of blood flow. ACS clinically present, remember, with OPQRST. It is sudden in onset, crescendo pattern, increasing in intensity, no? It has usually provoked by activity, extreme emotion, and it does not usually respond to your sublingual nitroglycerin. In some instances, biglaan lang, even walang ginagawa. Kaya nga yung mga heart attacks, nangyayari sa madaling araw because yung mga nocturnal changes, no, yung sudden rise of BP, particularly in the morning. And usually they describe as squeezing, tightness, and crushing. It may radiate to the arm, chest, mandible, no? And usually lasts more than 30 minutes. All right. In summary, again, it is sudden in onset, usually provoked by the activity, but it is usually spontaneous. It's described as squeezing, diffuse, can radiate to the arms, to the jaw, mandible. All right. It is lasts more than 30 minutes. And the usual risk factors among patients with acute coronary syndrome includes hyperglycemia, of course, vices, smoking, poor diet, poor sleep, family history of CVD, or your cardiovascular disease, poor fitness, obesity, no, insulin resistance, of course, your diabetic kidney disease, dyslipidemia, and of course, your hypertension. So going back to the case again, when you see a case like this or when you're doing your history and physical examination, you should be able to highlight and pinprick, no? Nitpick those information that would lead you or think of a diagnosis. So, in this patient, since you have a strong suspicion, no, For acute coronary syndrome, what is the choice to determine the direction of management? Of course, the answer is your 12-lead ECG. It is fast and it should be done again in how many minutes? All right, put in your side notes 10 minutes. Your ECG should be done in less than 10 minutes. All right, just a basic review. These are your ECG waveforms. There's a P wave, which corresponds to your atrial depolarization. The PR segment, that's the distance between the P and the QRS complex. Okay, that's the time the impulse travel from the SA node to the AV node. The QRS complex is your response to your ventricular depolarization, while your T wave is your corresponds to your ventricular repolarization. So these are the different three ECG scenarios. STEMI, there's ST segment elevation. There could be ST segment depression for NST-ACS or non-ST elevation of the coronary syndrome, and or T-wave inversion. So for patients presenting with STEMI, urgent revascularization, either thrombolysis or PCI, again, the objective is door to balloon time of 90 minutes, door to needle time of 30 minutes. Now, there are new terms that you might encounter, no? FMC. FMC pertains to first medical contact. No? First medical contact to wire crossing, need to say, natawid yung bara ng coronary angioplasty should be less than 120 minutes. All right. Now, on contrary, for NSTEMI, it's primarily medical, unless they present with high-risk factors which will warrant invasive strategies such as refractory chest pain, persistent ST deviation, ventricular tachycardia, and your hemodynamic instability, and your signs of heart failure. Now, at the ER, the patient was noted to have elevated blood pressure of 150 over 100 and a heart rate of 130, all right, over 100. Cycles per minute. And you ordered for a stat-12 ECG. If you're suspecting STEMI, which leads on the ECG will show ST elevation. Kung wala kayong idea, what's just a quick guess? Is it leads V1 to V2, V3, V4, V5, V6, or V2, 3 AVF? Doc, malalaman po ba namin kung saan may STEMI yun? Kapag ganito lang ang information? Okay. Of course, walang 100% sa medicine, but more often than not, there are trends that we recognize in patients presenting with STEMI. Now, if there is actually a STEMI presenting with hypertension and tachycardia, it can have an anterior wall MI, which corresponds to your V3, V4. Now, what are the walls and ECG leads among patients in the ECG? So your ECG corresponds to several walls. V1, V2 is septal. It usually pertains to your proximal LAD. Your V3, V4, your anterior wall MI, is also pertaining to your left anterior descending coronary artery distribution. V5, V6 is your lateral, usually with the left circumflex. The 2-3 AVF is right coronary artery, and of course your 1 AVL is your left circumflex. Different references might cite you, different sources or different percentages, but how does they fare in terms of presentation? So majority of the patients present with right dominant circulation. When we say right dominant circulation, the posterior-descending artery and the posterior lateral artery originates from the right coronary artery, which is approximately 80 to 85% of the time. In 10 to 15% of the time, the PDA or the PLA originates from the left circumflex, all right? And in the either 10 to 15% of the time, the PDA and PLA is shared both by the right coronary artery and the left circumflex artery. But again, those are for advanced questions. But it's nice to know that you guys know that 80 to 85% of the time that the patient has right dominant circulation, wherein the PDA, posterior descending artery, and posterolateral artery originates from the right coronary artery. Now, going back to the case, Doc, paano nyo po nalaman ang anterior wall? Bakit? Dahil ba hypertensive and tachycardic. Okay. So, patients with anterior wall, no, not all that time, no, they might present with James reflex. So, this is usually anterior wall, V3, V4, no? And they are stimulating the sympathetic drive, no? Because ang nangyayari pag nagkakaroon ka ng anterior wall MI, remember the LV is the one that is affected. So kapag nagkaroon ka ng MI sa left ventricle, magkakaroon ka ng decrease ng cardiac output. Pag nagkaroon ka ng decrease ng cardiac output, masisense yan ng sympathetic nervous system mo, ng brain mo, kailangan nating increase yung cardiac output by secreting your norepinephrine and epinephrine, no? Your adrenaline, your noradrenaline. So, ang effect nun sa heart rate, bibilis, tachycardia, and effect ng blood pressure because magkaroon ka ng peripheral vasoconstriction. Remember that the formula for blood pressure is equal to cardiac output times peripheral vascular resistance, and your cardiac output is equal to heart rate times stroke volume. So kung mababa yung stroke volume, you want to improve the heart rate and you want to increase the peripheral vascular resistance. That's a direct proportion, no, for your blood pressure. So kaya nagkakaroon ng usual, no, ng anong tawag dito, ng tachycardia and increased blood pressure for those with anterior wall MI. In contrast, no, for patients presenting with inferior wall MI, that is ST elevation in leads 2, 3, and AVF, they might present with bradycardia and hypotension, no? And inferior wall, the 2-3 AVF usually involves the right coronary artery. So at this level, no, parasympathetic naman yung na-activate. So nagkakaroon ka ng bradycardia at saka ng because of that, no, decreased stroke volume, nagkakaroon ka naman ng decreased ng blood pressure causing hypotension. So these are some examples of your ST elevation, no? It's anteroseptal and of course your high lateral wall. Your NSTA is an example of your ST segment depression and of course your T-wave inversions. So these are the labs to order, no? Your 12-lead ECG again should be taken less than 10 minutes. Usual findings include ST depression or elevation, of course your T-wave inversions, and non-specific findings, your blood chem, no, in order to help us determine the appropriate doses, particularly the renal function. CBC, again, WBC may elevate up to 12 to 14, no, as part of the neutrophilic predominance because, again, inflammation ng heart attack. Lipid profile should be taken within 24 hours, otherwise do not order it. It may be elevated or normal. Troponin, of course, vary in different levels. Now, there's high sensitivity, there is your conventional, but if you're using high sensitivity, this can be taken on admission and after 3 hours. For traditional, take it on admission and may take for 6 to 8 hours. So some of you might ask, Doc, wala na bang CKMB? Yes, you can still order CKMB. The difference between troponin and CKMB, troponin can remain elevated up to 7 to 10 days after the heart attack. If you're considering new onset ACS, you put it on your side notes, pwede nyong i-order yung CKMB because 3 to 4 days lang bumababa ni CKMB after a heart attack. So after a week, no, pwede kayong mag-order na kung nagko-consider ka ng bagong onset ACS. There's a elevation of your CKMB in particular. Of course, to the echo to see wall motion abnormality, check your cardiac function. Again, for patients who have ischemia, no, they can have ischemic mitral regurgitation because the papillary muscles are not contracting adequately, causing yung MR and CT coronary angiogram. All right, for patients who have intermediate, but of course, if you have high likelihood that the patient has ACS, you already proceed with your coronary angiogram. So, since the patient exhibited STEMI, no, you decided to send him for coronary angiogram angioplasty. Again, this is pharmacology. Which of the following is the correct combination of antiplatelets prior to sending the patient to cath lab? All right, I really want you to be familiar with the loading doses. Aspirin can be given as 180 to 300 milligrams. That's 4 tablets chewed and swallowed because the Philippines has a 75 dose, no? Clopidogrel is 75 milligrams. If your patient is managed medically, 300 should be fine. But if you're sending your patient to angioplasty, 600 is the appropriate dose for your patient. Ticagrelor is given as 180 loading dose, then 90 milligram BID. Prasugrel is not available, no? But it is usually loaded as 60 milligrams, and then 10 milligram OD for more than 60 kilos, and 5 milligram OD for less than 60 kilos. Silostazole is being given as an off-label. If your patient has aspirin allergy, your silostazole can be given as an alternative. Adjunctive therapy includes your ACE-ARB. We usually use a short-acting captopril, no? There's the reason why of the frequency of the dosing, 1/4 Q8, and you titrate it accordingly based on the blood pressure. Beta blockers, again, to decrease the workload of the heart, to improve the oxygenation and control the symptom. Again, the target heart rate should be less than 60, 55 to 60 beats per minute. So you can control it using your metoprolol 50, 1/2 Q6. And again, statins, you need to use high intensity doses. And then there are two statins with high intensity. This is your atorvastatin 40 to 80 and your rosuvastatin 20 to 40. If you're going to use heparin drip, no, you have to target a PTT 2 times the control. Or if you're going to use your low molecular weight heparin, you don't need to monitor your PT or PTT. You just need to give your enoxaparin 1 milligram per kilogram every 12 hours. Your nitrates can be given as a drip and as an oral. If you're going to give it an oral, remember that you have to give at least more than 8-hour nitrate-free period, no? So ako, when I give my nitrates, I give it ISDN 5 or 10 milligrams, TID given at 7 a.m., 11 a.m., and 4 p.m., or 8 a.m., 12 p.m., and 5 p.m. Bakit ganoon in dosing? Going back to pharmacology, nitrates are very notorious for tolerance. So what is tolerance? Tolerance is a term in pharmacology wherein when you give the dose of the drug, it does not meet the desired effect of the drug. To counteract tolerance, you have to increase the dose of the medication. Now, there's also what we call tachyphylaxis. What does tachyphylaxis mean? Tachyphylaxis is again a pharmacologic term, no, which describes that even you increase the dose of the medication, the medication does not exhibit the desired effect. So that's the reason you want to give your nitrate-free period in order to prevent tolerance. Lactulose as a stool softener and of course your protein pump inhibitor, binigyan nyo na maraming pampadugo para na ma-prevent yung stress, no? Stress-induced gastroenteritis. All right. Now, going back the questions. Which of the following chest pain description would most likely point to a possible acute coronary syndrome? Is it aggravated by palpation, inframammary location, response to sublingual NTG, or pain lasting more than 10 minutes? If you listen to my lecture earlier, no, although I said that ACS is more than 30 minutes, for patients with CCS, then tumagal na more than 10 minutes, ACS already should be considered. All right, which among the following laboratory parameters will dictate management? Again, it's ECG. Given the clinical picture of angina chest pain, which of the following features will lead you to proceed to urgent coronary angiogram? Possible angioplasty. This is, of course, your hypotension requiring vasopressor support. And question number 4, 63-year-old male came in for sudden onset chest pain, revealed inferior wall STEMI. Which of the following medication is contraindicated? It is your beta blocker, no? All right, beta blockers are contraindicated in inferior wall MI. Again, it's also important, no, that you take right-sided chest leads, no, or your right, because if there is right ventricular involvement among patients with inferior wall MI, your nitrate should also not be given. But if there is no RV involvement, you can give your nitrates. Now, what is the most common cause of in-hospital death among patients suffering from acute coronary syndrome? The answer is your pump failure. Okay, let me go back again, no, to the contraindications, no. Why is beta blocker contraindicated in inferior wall MI? Remember that the right coronary artery is the one supplying the SA node, the atrioventricular node. Patients who sometimes present with inferior wall STEMI might present with bradycardia because the thrombus might also occlude the artery supplying the SA node or the atrioventricular node. Hence, we are trying to avoid giving beta blockers in order to prevent or aggravate the atrioventricular block that is usually a complication of your inferior wall STEMI. Okay? All right. Sige, let's proceed to valvular disease. You may pause the video if you want to take some water, go to the bathroom, no? So, since I'm recording this, I'm going to continue already. All right. So, valvular disease, for us to be familiar lang, no, with diastole, systolic, diastolic murmur. Let's have a quick review of your cardiac cycle. So, in systole, no, the left ventricle is being emptied. So, kung ito yung right and left ventricle, pumipiga sila, no? Yun yung time na nagsisistole. So, the blood is emptied out of the ventricle. So, the blood goes to the pulmonary circulation in the case of the right ventricle, and for the left, it goes to the aorta, no, to go to the different parts of the body. So kapag systole, ang bukas ay pulmonic valve kasi gusto mong dumaan yung dugo papunta sa lungs, and your aortic valve kasi gusto mong pumunta yung blood papunta sa systemic circulation mo. Ang sarado dahil ayaw mong bumalik, no, yung dugo from one chamber to the previous chamber. Sa right, sarado yung tricuspid valve kasi ayaw mong bumalik yung blood papunta sa right atrium. In the case of the left ventricle, sarado yung mitral valve because ayaw mong pumunta yung blood papunta sa left atrium. So again, systole, contract yung LV and RV, yung blood papunta sa lungs, papunta sa aorta, bukas ang pulmonic valve, bukas ang aortic valve, sarado ang tricuspid valve, sarado ang mitral valve. Now, sa case ng diastole, bumubukas, no? Nagre-relax yung left and right ventricle. Pag nagre-relax kasi yung right and left ventricle, no? Magbubukas ngayon yung tricuspid valve at si mitral valve para punuan ng blood yung right and left ventricle. Sa pagbukas na yun, paghigop ng blood, no, ng right and left ventricle, since ang opening ng aortic valve pataas, may higop siya pababa. Kaya magsasara yung aortic and pulmonic valve ninyo. Para yung blood going to the lungs or that went to the lungs and the aorta will not go back, no, to your right and left ventricle. Again, diastole, relaxation ng RV and LV. Gusto mag-refill ng dugo, no? Kaya magbubukas doon yung mitral valve and tricuspid valve, sarado ang aortic and pulmonic valve. So this is what happens, no, during your cardiac cycle. So kapag lumalaki yung puso, ang nagbubukas yung tricuspid valve, no? Yung tricuspid valve at saka yung mitral valve. Yung nakikita nyo dito sa screen, I think that's a pulmonic valve. Pagka nag-contract yung puso, bumubukas siya para mag-exit yung blood. So that's what happens. Now, what happens when there is a stenosis and a regurgitation? Just a quick reminder, kapag stenosis, may problema sa pagbubukas, no? So, kapag yung murmur ng aortic and pulmonic stenosis, kasi pag stenosis, ang nangyayari, yung murmur na marinig nyo, during the time na kung saan dapat may magba-blood flow sa kanila. So, ang aortic and pulmonic valve stenosis, dapat makakarinig ka ng murmur kapag may dadaang blood sa kanila. And that happens during systole kasi doon mag-eject yung blood, no? For mitral and tricuspid valve, kailan ba dumadaan yung valves ay yung blood sa kanila? During diastole. Kaya yung murmur na maririnig mo for mitral and tricuspid valve are during diastole. Now, if there's a problem sa closing ng valve, hindi masyado naglalapat o talagang pangit yung pagkakalapat, nagkakaroon ka ng regurgitation or tagas. So, kung kailan sarado dapat yung mga valvula, no? Like yung aortic and pulmonic valve, nakakarinig ka ng tagas, meaning to say backflow, during diastole. Kasi ang purpose nga ng valve para pigilan yung backflow eh. So, pag nag-relax ngayon yung aortic and yung LV tsaka RV ninyo, doon siya pwedeng humigo from the lungs at saka sa aorta. Kaya nagkakaroon kayo ng diastolic murmur kapag merong aortic regurgitation or pulmonic regurgitation. And for patients with mitral or tricuspid regurgitation, it happens during systole kasi doon sila dapat sarado, no? Kaya lang dahil hindi maganda yung pagkakasara nila, kaya pag nag-pump yung blood, yung right and left ventricle, dahil hindi maganda yung pagkakasara ni RV, ay ni tricuspid valve at pulmonic valve, may tumatagas no, sa mitral and tricuspid valve, causing the systolic murmur of MR and your TR. So these are the different auscultatory sites. No, you have your aortic, pulmonic, no, tricuspid, and of course your mitral. Ako po ay taga Manila. So, APTM. Ako po ay taga Manila. Aortic area, second ICS, right parasternal border. All right, your pulmonic area, usually the second, no, ICS, left parasternal border. Third or fourth ICS, yung tricuspid area. And of course, anterior, no, axillary, anterior mid-clavicular line, yung usual auscultatory site ng mitral valve area. So let's discuss a specific valve pathology. Let's look at your mitral stenosis. Say a 30-year-old female with history of rheumatic fever presents the emergency room with dyspnea and palpitation. On auscultation, there is an opening snap followed by a low pitch rumbling. Sorry, that should be rumbling, hindi tumbling. That's typographical error. Rumbling diastolic murmur at the apex. So what is most likely the diagnosis? It's mitral stenosis. Again, bakit nga diastolic? Kasi doon yung time na nagfo-flow yung blood papunta sa left ventricle. Ano? So, mitral stenosis, mayroong problema sa pagbukas ng valve. Kaya nangyayari yon kapag nag-relax yung LV nyo, nag-empty yung blood from the LA to the LV, there is turbulence causing the low-pitch rumbling diastolic murmur. What's the most common cause? It's usually rheumatic fever. And on X-ray, makikita kayo na straightening because of your left atrial enlargement. And usual treatment of choice is percutaneous transmitral commissurotomy or valvotomy. Binubuksan namin no, yung masikip na valvula. Again, the predominant cause is rheumatic fever, and 25% of patients with rheumatic heart disease have isolated mitral stenosis. 40% have combined MS and MR. 2/3 of patients with rheumatic MS are female. Bihira yan lalaki may MS. And interval between the initial episode of rheumatic fever and the development of mitral valve obstruction usually is 20 years. No? Clinically, they present with elevated atrioventricular pressure gradient on 2D echo. So, ano bang ibig sabihin ng pressure gradient? Na-measure kasi namin based on echo, no? Echo is talagang echo ng sound. Yung probe, pag nilagay mo sa heart, magbabato ng sound, tapos titingnan yung feedback, no? So, na-measure namin yung pressure before the mitral valve and after the mitral valve. If there is a difference, no, in the pressure before the mitral valve and after the mitral valve, then there is a gradient. So, usually mataas yung gradient sa left atrium compared sa left ventricle after the mitral valve. And the most common presenting symptom is dyspnea, fatigue, and decreased exercise tolerance. They might present with hemoptysis or hoarseness, lalo na kapag nagko-congest. Usually, they have a loud accentuated S1 or what we call the opening snap, no? There's a low pitch, rumbling, diastolic murmur at the apex, and the convulsion sign, lalo na kapag nag-develop ng pulmonary hypertension, nakaharang ka na yun ng functional tricuspid regurgitation. ECG will show left atrial enlargement. How does left atrial enlargement present with ECG? That is a P wave na mataas, no? Sorry. That's a P wave na parang wide P wave on ECG. In leads V1, parang ano siya, meron kang positive deflection pataas, tapos negative deflection pababa. Alright, biphasic. So, if you can notice, no, in the screen, ang itsura ng ECG natin, no, usually they usually have a bifurcation. So, kung ito yung line sa ECG, no, dalawa yung nakikita niyong wave. Merong pataas at pababa for patients with mitral left atrial enlargement. And of course, on X-ray, makikita kayo na straightening ng cardiac silhouette, no, hindi siya yung may bewang. Straight siya yung LA papaba sa LV. So, of course, 2D echo is the most accurate approach to the diagnosis and evaluation of MS. Characteristic anatomy, which might be asked, no, in your board exam, there's outlet thickening, restriction opening by symmetric fusion of commissures resulting in the doming of leaflets and diastole, the hockey stick sign, no? So this is the image of your mitral stenosis. To the left, no, this is the one that presents with mitral stenosis. So makikita nyo, no, parang gumaganon, no, hindi bumubukas. In contrast to the image on the right, pumapalo yung mitral valve. So that's the normal opening. Pag mitral stenosis, limited, no, restricted. If you're going to look at the itsura nun sa view na cross-sectional, no, short axis view, notice no na parang there's a commissural fusion, no? Para siyang fish mouth pattern. So these are the different mitral valve area and their corresponding severity. You want to memorize the valve area, no? In the previous sessions, I think it was asked, no? The mitral stenosis severity based on the valve area. So management, you want to decongest your patients, you want to slow down the heart rate with beta blockers, digoxin, or non-dihydropyridine calcium channel blockers. Why do you want to decrease the heart rate? Again, to prolong the diastolic feeding time. Mas matagal mag-relax yung LV, mas matagal mag-empty. No? If there's presence of AF, the only approved anticoagulant is your vitamin K antagonist in the form of warfarin. And then treatment of choice is PTMC and mitral valve replacement. Surgery is actually the definitive choice. And of course, you have to give penicillin prophylaxis, either injection or daily with oral medication. Now, in the exam, they might ask you what is a contraindication for doing a valvotomy if there is a presence of thrombus. That's number one. Number two, if there is a presence of moderate to severe mitral regurgitation. Kasi pag binuka niyo yung balloon, sa PTMC, no, this is an example of how we do a PTMC. We create a parang atrial septal defect, not just very small. And then we put a balloon across the mitral valve and balloon inflated to open. So for patients with severe, mild, moderate to severe MR, we might worsen it, no, kapag binuksan natin yung mitral valve. Another valve lesion is your aortic regurgitation that I want to discuss with you. Say of a patient with 62-year-old with history of hypertension, complaints of fatigue, shortness of breath. No, on physical examination, there's a high-pitched blowing diastolic murmur at the left parasternal border. Doc, bakit ganon? Sabi nyo, ang auscultatory site for patients with aorta, on the aorta is the right parasternal border, but for the aortic is usually the left. Alright, for AR kasi, I remember that the lesion or the murmur is caused by the backflow, no, of the blood going back to the ventricle. So, kung aortic valve papunta dito, dapat ang aortic stenosis, ang aortic regurgitation, pababa sa left ventricle. Kaya usually, nasa left na siya. Alright, even though we have the auscultatory sites, it is not absolute, and such as in the case of an AR. So, what is most likely the diagnosis? It's aortic regurgitation. Again, the diagnostic of choice is your transthoracic echocardiogram. What should be avoided? Beta blockers, because you don't want to prolong, no, the diastolic filling time kasi mas mag-worsen yung AR nyo. Alright. It is majority caused by a primary valve disease or aortic root disease. No? It can be a complication of aortic dissection, Stanford A, no, or DeBakey 1, kasi yun yung involving the aortic root. No? Acute AR is actually severe and life-threatening. It can cause pulmonary edema and cardiogenic shock, and of course, your chronic severe aortic regurgitation. These are the ones that are more tolerable kasi nakapag-a-adjust na yung katawan ng tao. Now, I want you to remember your AR man, no? These are the different signs for patients with aortic regurgitation, but I would like to discuss to you the more common ones, no? The demo set sign, yung bobbing of the head. Yung mga ganun-ganun yung patient. Oh, sorry, mukha akong engot. Then the lighthouse sign, itong forehead, no? Kaya dyan sa AR man, nakikita niyo yung forehead may kulay pala. Ano ba napapansin niyo sa lighthouse? Di ba umiilaw tapos nawawala? Umiilaw, nawawala kasi nag-rotate yung light. So, sa lighthouse sign, yung sa forehead ng patient, nakikita niyo, namumula, namumuti. That's rarely seen, ano? Tapos, yung Landolfi sign, if you observe closely yung pupils ng mga patient, nagdadilate, no? Nagko-constrict during diastole and systole. So, yun. Becker sign, yung retinal arteries naman, nakikita niyo yung prominent constriction and dilation, ano? Muller sign, yung uvula, nagwiwiggle, no? During systole and diastole. And of course, the water hammer pulse or your Corrigan's pulse or your Corrigan's next sign, yun yung rapid upstroke and then biglang baba. So, yun ang isang mga nakikita. Quincke's sign, if you look at the nails of your patients with AR, makikita nyo ano doon sa root. Yun, same as the lighthouse sign, namumula, namumuti, namumula, namumuti. Now, this is a really very interesting auscultatory findings. Yung sa singit, no? We have the Dorothy, which is the piston shot niyo para nakarinig kayo ng nagpaputok ng barel. The reason for that is kapag nakapinato nyo kasi yung stethoscope nyo doon sa femoral artery, pag kasi nag-systole, tatama yung pulse, no? Doon sa stethoscope nyo, tapos biglang quickly biglang lalayo yung artery kasi nga biglang mag-AR. Yung blood, no? Babalik sa blood, so biglang babagsak yung femoral artery distension. So parang whoosh, ganun siya, whoosh, whoosh. And then of course you have a 2 and 4 murmur, no, as your Taub sign. And of course your Hill sign, wherein there is a 40 millimeter mercury difference between the brachial and of course your popliteal artery blood pressure. So for acute AR, of course, we have to diuresis. We have to avoid beta blockers. Again, surgery is the treatment of choice and necessary and should be done usually within 24 hours. ACE inhibitors, ARV for chronic, diuretics, and of course, your calcium channel blockers to vasodilate, no? Kumbaga, it's an afterload unloader. And of course, SAVR or surgical aortic valve replacement is the treatment of choice for patients developing heart failure on AR. All right. Okay. Last few topics are your heart failure. Let's look at a case. A 65-year-old man presents to your clinic with fatigue, shortness of breath after climbing 2 flights of stairs. His symptoms started 2 weeks ago and have progressed gradually. He has a history of hypertension, MI. For 1 year, an examination, there's jugular venous distension. On auscultation, no, there's bibasal rals. And of course, pag pinindot nyo, there's pating edema. What's most likely diagnosis? Okay, heart failure. What's usually the NIHA? Functional class. At least it's functional class 2. Pwede pa nga functional class 1 kasi 2 flights of stairs. Stage C. Again, we have A, B, and C. A is at risk. B is meron ka ng structural changes sa heart without symptoms. Stage C is meron ka ng structural symptoms. Meron ka ng structural changes and meron kang symptoms. And of course, stage 4 you're already bedbound, you're symptomatic even at rest. The test of choice is of course echocardiogram because the newer classification of heart failure and the ones that we use for treatment decisions is the ejection fraction, and mechanism of this niya is usually pulmonary congestion. So what is heart failure? It's a diagnosis based on clinical symptoms, no? It can be secondary to your structural or functional impairment of ventricular filling or ejection, and usually presents with dyspnea and fatigue, and of course, signs of edema and rals. So we have the systolic or heart failure with reduced EF. The EF is usually less than 40%. There's a decrease in the pumping ability, contractility of the heart. The most common cause of your CAD, dilated cardiomyopathy, your valvular heart disease. And while your diastolic heart failure is usually preserved more than 40 to 50%, there's a problem in ventricular compliance. The more common causes are your hypertension, HOCM, aging fibrosis, or your restrictive cardiomyopathy. And there's what you call the high output failure. Wala kang problem sa heart initially, no? Walang problem sa EF. There are some causes, no, na decreased, no, nutrients such as your beriberi, your anemia, thyroid thyrotoxicosis and your atrial fistula. So they present with the following signs and symptoms, no, orthopnea, nocturnal cough, exertional dyspnea, PND, Chine-Stokes respiration, cardiac akasia, pero these are the severe form, elevated JDP or jugular distension, presence of auscultatory S3 or S4, congestion, hepatomegaly, ascites, no, lalo na kapag nag-develop yung patients nyo ng chronic passive congestion of the liver, peripheral edema, and cool extremities kasi nga vasoconstricted. So again, these are some of the symptoms and signs of your heart failure, no? Distended neck veins, no? There's actually pulmonary congestive changes, there's cardiomegaly, no? And the presence of your auscultatory S3 and S4. Pakinggan nyo lang. So, di ba, instead of lab-dub, 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 that's the normal heart sound. Sa kanila, lab-dub, lab-dub, dub. Parang meron kang sound before the S1, no, which is the S4. S4 is the contribution of the left atrial emptying, no, while S3 is the sound wherein when the blood flows, no, to the left ventricle, tumatama sa stiff wall, no, the stiff left ventricle. So, okay, hopefully it will immortalize in your ears. Okay, moving forward. These are the different NIHA functional classifications. Again, 1 can climb 2 flights. All right. Functional class 2 can climb 2 flights but with difficulty. Functional class 3, less than 1 flight, several steps pa lang hinihingal na. And functional class 4, even at rest. No? Again, these are the different stages of heart failure. A is at risk. Letter B, may structural heart disease but no symptoms. C has both disease and symptom, structural changes and symptoms. D are those with our marked symptoms despite optimal medical therapy. This includes the workup, no, in order for us to adequately manage patients with heart failure and, of course, control the risk factors. This includes your CBC, your blood chem, your cholesterol and sugar, thyroid function, ECG, X-ray, and of course, the most important, echocardiogram and biomarkers or NT-proBNP. And the goals of treatment is symptom relief, prevention of disease progression, and mortality reduction. And these are the medications. Of course, in the armamentarium of heart failure, the first 4 medications that are utilized is ARNI, your angiotensin receptor neprilysin inhibitor, your sacubitril valsartan. When I was a medical student, it is still called as LCC 696. However, the trial for this was stopped prematurely because of the significant benefit this medication has given to humankind. This is actually a wonder drug. I've seen my patients who have EF of 22 to 25%. When I start them on sacubitril valsartan, after 6 months to 1 year, nagiging preserved na ulit yung EF nila. Tumataas as much as 50 to 60%. Now, ACE inhibitors are given, if the patient by any chance cannot tolerate your ARNI or your are unable to afford kasi that is quite pricey. Aldosterone antagonists are also important, examples of which are your spironolactone or epinephrine. And of course, your diuretics for your acute heart failure. Others, of course, ito yung mga bagong gamot, I think this will be discussed in your diabetes and discussing pharmacology. Your SGLT2 inhibitors, these are actually anti-diabetic meds, which we are actually slowly, using or parang inangkin na namin for heart failure. Your dapagliflozin, your empagliflozin, these are studies, that were observed, even for patients who are non-diabetic, have significant mortality and adverse cardiovascular event benefit for patients with heart failure. So the 4 pillars of heart failure management, include number 1, your ARNI, if hindi ma-tolerate si ARNI, your ACE inhibitors, followed by your aldosterone antagonists, and then of course your SGLT2 inhibitors. So 4, it's either ARNI or ACE, aldosterone antagonist, and your SGLT2 inhibitor. Not included in the slide, and this include this in your notes, are your beta blockers. So I want you to include in your notes your beta blockers, These include the following. There are only 4 beta blockers, that are approved for the use of in the heart failure because of their mortality benefit. If you're going to read the ACC-AHA guidelines, The beta blockers that are very important for them are your metoprolol, succinate, no, followed by your bisoprolol, and lastly is your carvedilol. No? Among the three, the beta selective is your metoprolol and your bisoprolol. The non-beta selective is your carvedilol. If you're going to look at the European Society of Cardiology heart failure guidelines, of course, the one that is added, no, in the beta blockers is of course your nebivolol, no, is also a beta 1 selective beta blocker. Again, please do include in your notes, no, the beta blockers, metoprolol succinate, bisoprolol carvedilol, the ACCHA, and of course if you're going to look at the ESC, they include nebivolol as part of their armamentarium. Now, the second column that I have indicated, the ARBs, no, their losartan, again, the recommendation for ARBs are only given if the patient cannot tolerate your ACE inhibitors. Ivabradine, if you're not able to target a low heart rate, your hydralazine plus nitrates for patients who are suffering from acute kidney injury, wherein you cannot give your RNA ACE or your ARB, and of course, digoxin is one of the last line treatment for heart failure. Okay? Sige. Last topic for cardiology is of course your cardiac tamponade. Cardiac tamponade, no, is pagkakaroon ng water, no, inside the pericardium. Your heart naturally has fluids in the pericardium to lubricate it. But more often than not, sometimes, no, because of different conditions, nag-accumulate yung fluid causing cardiac tamponade. And I'm going to discuss this to you in this segment. Alright. Say a 43-year-old woman with systemic lupus erythematosus presents with chest pain and progressive dyspnea. On examination, blood pressure is 70/50. There's distended, no, jugular veins, muffled heart sounds, and pulsus paradoxus. Ay, pulsus paradoxus yung biglang bumaba yung blood pressure. Alright. So what is most likely the diagnosis? It's cardiac tamponade. Was the most urgent step kasi this is again an emergency. You want to relieve, no, the heart with water. It's an echocardiogram guided pericardiocentesis, and how much fluid should be is necessary to produce, no, can be as small as 200 milliliters, no, if this develops very rapidly, to as much as 2,000 for chronic effusions. So in the Philippines, the most common etiology is tuberculosis, followed by malignancy, and of course, your chronic kidney disease. TB is usually drained, no, and it's usually resolved by anti-TB meds or anti-COX medication. Malignancy, on the other hand, no, these are rapidly or slowly accumulating fluid, which we have to drain regularly, no, until we are able to control the malignancy. CKD usually doesn't require, unless the patients present with tamponade, kung pericardial effusion lang natin tamponade physiology, hemodialysis can cause resolution of these symptoms. Clinical and laboratory manifestations, this include the Beck triad, hypotension, soft or absent heart sounds, jugular venous distension. So this is the Beck triad, no? Now, pag kasi yung patients umabot dyan sa Beck triad, we're too late to recognize. So what are the subtle signs that the patient has or in beginning tamponade or mayroon ng tamponade physiology? Number one, there's presence of tachycardia, no? Very fast heart rate. Remember, since there's fluid that's cramping the heart, hindi makapag-expand yung heart. So ang tendency ng heart, bumilis yung tibok in order to compensate for the cardiac output in a reduced systemic stroke volume. So another is you can listen for the heart, no, muffled heart sounds, no. So other features include your pulsus paradoxus, water bottle on X-ray, and electrical alternance, no. So usually patients with cardiac tamponade might present with this kind of X-ray. So I just use an ECG wherein there are big QRS complexes, no. This is an example of electrical alternance. You can notice that there are big QRS and small QRS. Meaning to say, nagsisway kasi yung heart inside the fluid, no, ng pericardial sac. Now, in some instances, the very severe ones, no, they may also present with low voltage complexes. Meaning to say, yung mga ECG, ang liliit. Tapos makakita pa rin kayo ng alternance. So those are those are laboratory suggestions that your patient is having pericardial effusion and tamponade. So treatment again is echo-guided pericardiocentesis of subxiphoid thoracotomy, pericardial window placement, and of course, your pericardiectomy or pericardial stripping. Bubutasan nyo na talaga yung pericardium para nilidrain, no? Sa tiyan, yung tubig. So, sa arrhythmia, your Brugada syndrome. So, these are what you usually call as the bangungot, no? Recently, we have launched the Philippine Bangungot program wherein the objective is to recognize, prevent, no, sudden cardiac death be brought by Brugada syndrome. So, let's look at what is Brugada syndrome. Let's begin with the case. Now, say, for example, a 25-year-old male with no known comorbidities, with vices, with good baseline capacity, suddenly collapsed and was found to be unresponsive. Family history revealed that he had an uncle who also died at 33 and an elder brother who died at 29 years old, both during sleep. What is most likely the diagnosis? Bakit hindi siya ACS? Kasi number one, bata siya. Pwede bang pancreatitis? Pwede. Kaya lang pancreatitis, sobrang lala naman, no? Talagang bawat family member nila namamatay. Stroke in the young? Pwede. Pwede, kaya lang. Usually, the most common cause of stroke in the young is yung meron kang cryptogenic stroke, no? Yung parang ASD. So, the most common, particularly pare-parehong lalaki, very young, no? Mga 20s to 30s, these are highly suggestive of Brugada syndrome, particularly of Asian, Southeast Asia or Japanese descent. So, what is Brugada syndrome, no? This is the most common cause of sudden death among patients that is not ischemic, no, in nature. So, this is considered among Asians and Southeast Asian males, no? Ito yung tinatawag na bangungot. Again, they are presenting with ventricular fibrillation, yung arrhythmia of the heart, no, which is an ineffective contraction causing death sa mga patients who are not being able to revive. Sometimes sa mga patients natin na nagbubrugada syndrome, nalalaman na lang may brugada sila dahil na-revive sila from sudden cardiac death. We have actually one patient in we have a staff in PGH, no, who is diagnosed to have brugada because na-revive siya from a sudden cardiac arrest. And right now, meron siyang ICD. Unfortunately, walang treatment for that would reverse Brugada syndrome. Meaning to say that would definitely treat no Brugada. Okay. So the pathophysiologic mechanism is not fully understood, but the most commonly accepted is again, remember this, no, is the loss of function mutation in your SCN5A gene. Not to be confused with gain of function in mutation in SCN5A, which is known in the long QT syndrome. Okay? Again, pag Brugada, loss of function. Pag gain of function, this is your long QT syndrome. All right. So what are the diagnostics? Of course, ECG, no? We have three types of your Brugada pattern. We have the type 1, we have the type 2, and the type 3 saddleback. Of the three types, no, type 1 is the one associated with sudden cardiac death. So these are the different, no, ECG patterns. Look at V1 and V2. Some people who are not familiar with these tracings might read this as incomplete right bundle branch block or complete right bundle branch block. But it's very important for you to recognize, no, the ST pattern, no, Cove type ST segment elevation pattern among patients in ECG. And based on the 2013 consensus on how to diagnose, no, Brugada, there should be documented VFib, family history of sudden cardiac death, no, less than 45. Families of type 1 Brugada pattern with ECG, or you can induce it, no, during EP study. Unexplained syncope suggestive of tachyarrhythmia and nocturnal agonal respiration. All right. In terms of management, we have to avoid your antiarrhythmics. Example, your class 1 antiarrhythmics, your Ajmalin, flecainide, and ranolazine. And all the treatment of choice is, of course, effective. The only effective is ICD implantation, no? To reset your VTAC and VFib. Pharmacology, you can treat it with amiodarone once daily after initial loading dose of 400, 2 to 3 times daily for 1 to 2 weeks. All right. I hope with the selected topics of cardiology in internal medicine, I was able, no, to impart to you, no, the must-knows in cardiology. And I hope when you also read the other parts of cardiology in your IM handout, you'll be able to process the information the way we did, no, in tackling all these select topics in cardiology. All right. I bid you good luck. I pray for you for your success. I hope, no, that you become all of my colleagues, and I hope some of you will go to cardiology, because again, cardiology diseases are the number one cause of non-infectious, no, causes of death in the Philippines and worldwide. And being a cardiologist, maraming mag-refer sa inyo, marami kayong matutulungan may sakit. Alright, God bless. Praying for your success. See you on the next slide. Thank you and goodbye.